today we'll be covering obstructive sleep apnea in children. So we see Michaela in surgery today. She's 4 years old. She's been brought in by her parents. Her parents are very concerned because Michaela has been very restless and she snores loudly throughout the night. During the day, she's very irritable and also hyperactive. No past medical history of note, though you do notice her weight is on the 90th centile. You examine her and she is feral. She's tearing up your room. She's in and out of your doctor's bag. But you don't notice any obvious dysmorphic features. Her ears are okay. Her turbinates were a little bit swollen. You try and examine her throat. She tries to bite your fingers off. But you do notice she has large tonsils which are not infected or inflamed. She's an only child. She attends nursery. And there have been no concerns highlighted about her developmental milestones. So what's going on here? Is this simple snoring? Is this allergic rhinitis? Is this obstructive sleep apnea? Is this laryngeal hypertrophy? Or is this ADHD? Not a week goes past these days without parents bringing their children to me because they're concerned about underlying possible ADHD, a very common presentation in primary care, isn't it? And what do we do next for Michaela? Would we refer her to a pediatric dietitian? Would we refer her to pediatric ENT? Would we refer her to CAMS? Or would we just reassure parents that this is simple snoring? So sadly, we're in an era where we need to talk about obstructive sleep apnea in children, driven by a pediatric obesity epidemic. And this is a hot topic for us in primary care. We had 2 recent articles published, a 10-minute consultation published in the BMJ during 2017, and a clinical intelligence article published in the BJGP also during 2017. And it's commoner than we think. 1 to 4% of children can be affected by OSA and can have quite serious sequelae, right ventricular hypertrophy and cor pulmonale, and systemic hypertension if untreated. 2 types we need to be aware of: simple OSA, which is secondary to adenotonsillar hypertrophy in children with no real other significant past medical history of note. And then we have complicated OSA, which is secondary to another medical condition, such as obesity, craniofacial abnormalities such as cleft palate, Down syndrome, or other neuromuscular conditions such as cerebral palsy or Duchenne's muscular dystrophy. The key take-home message, though, for us all working in primary care is that the presentation of pediatric OSA is different to that of OSA in adults. OSA in children is more likely to present with behavioural problems, poor attention, and reduced academic performance rather than daytime sleepiness like we see in adults. So what are we looking for in the history of someone like Michaela? At night, we're looking for snoring, we're looking for disturbed or fitful sleep. Parents might witness obstructive apneic episodes, and in this era of smartphones, parents can simply video these episodes and show us in surgery. Secondary enuresis can be a clue, so if Michaela was dry at night and then starts wetting the bed again, this can be associated with OSA. Children with OSA can arch their neck at night to try and unobstruct their airways, so this can also be a clue. And of course, take any parental concern seriously. During the day, children may be irritable or excessively tired. They may be a mouth breather, and a useful way to test this is to put a spoon under the nose and look for misting or the absence of misting. There might be a nasal quality to speech, and there might be evidence of developmental delay or behavioural problems. And another key take-home message for us all in primary care, which has really changed my practice, is that 25% of OSA in children presents with symptoms of ADHD or poor school performance. So those many children that are brought in to see me with possible ADHD, I'm now looking a wee bit harder for underlying symptoms or signs of OSA. So this has been a real practice-changing point for me in primary care. On examination, look for growth, the growth centiles, look for any syndromic features, any craniofacial abnormalities. Look for mouth breathing as mentioned, and also look for stertor. This was a new word in my vocabulary. Stertor is quite a coarse inspiratory noise, a little bit like snoring but during the day. Do an ENT examination, looking for any nasal obstruction, looking for tongue and tonsillar size, and look for evidence of otitis media and glue ear. There's an association between OSA in children and glue ear. So what can we do for children like Michaela, and how can we support Michaela's parents? Well, if this is uncomplicated snoring with no additional symptoms or features or OSA, we can reassure Michaela's parents that she's likely to simply grow out of this. However, children with a history of snoring and additional features of OSA do need referred to ENT. And often, an adenotonsillectomy